Good evening. Want to welcome everybody to this week's Sagis Dermpath Happy Hour session. We're pleased to have one of our associates at Sagis will be giving our session today on viral conditions, Dr. Maloney. Dr. Maloney is a dermatologist, actually did dual residency in dermatology and internal medicine at Harvard, and has been on the faculty member. Has been a faculty member at UT Houston, MD Anderson for the past several years. Has recently will be leaving that position and going into private practice. Did her Dermpath fellowship at MD Anderson as well. Excellent teacher, and I know you guys will look forward to hearing from her. As always, if you have any questions at all, you can post them in the chat. I will be looking at those. Or you can email us any questions at education@sagisdx.com, especially for those of you who are not watching live. So without any further hesitation, we'll go ahead and turn the floor over to Dr. Maloney.
Thank you, Dr. Davis. So as mentioned, I'm Kuda Maloney, and today I'm going to be reviewing viral infections, which I think certainly it's a good moment in history to do so. And I really want to deal specifically with the effect of localized viral infection to the skin, or a viral infection in the skin, and what we expect to see there histologically, as opposed to the inflammatory dermatoses that can arise secondary to there being a viral infection somewhere in the system. Okay, so that's a whole different topic. So I'm going to go ahead and start sharing my screen here with you. And we might as well just jump right into the cases. And I'm going to reorient here. So with this first case, what we appreciate is a slightly raised papule on the skin. And then there's really looking at low power. And I do like that exercise of looking at each layer of the skin. So starting with the stratum corneum, we appreciate that there's this basket weave stratum corneum kind of open. And again, still at low power, we appreciate that there is something kind of interesting happening around the granular layer, but we'll come back to that at higher power. And then of course there is some papillomatosis and not much else. So this would really fall into the category perhaps of one of those invisible dermatoses. Not much to see until you start looking a little closer. Okay, so doing exactly that. So what we appreciate in the granular layer and in the upper stratum spinulosum is these large keratinocytes, really quite enlarged, that have this clear component in the nuclear area, right? So very large keratinocytes with this vacuolation is what we call it. And looking even closer, we appreciate that the nucleus is there, but it's dark and relatively small compared, for example, to some of these nuclei in the lower stratum spinosum and in the basal layer. And then it's dark, right? So small dark nucleus and enlarged keratinocyte with vacuolation in the cytoplasm. And in the cytoplasm itself, we may end up seeing they're clear looking, but there's actually something there, right? So these are koilocytes. So koilocytes are a consequence of viral infection. We call that viral cytopathic effect. The virus, of course, is too small for us to be able to see individual viral particles with the light microscope, but we can see the effect of the virus being there. So broadly, we call that viral cytopathic effect, and there are various different kinds of cytopathic effect. So we're going to go through the different types as we come across it. But in this case, we've appreciated that koilocytes are essentially keratinocytes that are exhibiting this viral cytopathic effect, where you have a small dark nucleus or pycnotic nucleus, an enlarged keratinocyte with vacuolation, and then viral inclusions may be present, okay, in the cytoplasm. In the granular layer itself, we of course expect to see keratohyalin granules kind of clumped together, so that we do appreciate that. But they just seem to be more cells that have many more of them, right? So we have more of these keratohyalin granules. They're just very robust and increased, okay? So putting this all together, we have this basket weave stratum corneum, and then limited to the granular layer and the upper portion of the stratum spinosum, we have coilocytes, and then there's this papillomatosis that's kind of mild. This is a good example of Verruca plana. Okay, all right, so Verruca plana. Moving on to the next case, and I'm going to reorient us here as well. So this is a very characteristic look. All right, so even at low power, lowish power, we appreciate that we have this really profound orthokeratosis with these tiers, these columns of parakeratosis, right? That is more prominent along these almost hills that we're seeing at the top of this lesion. This exophytic component. In this lesion, we also have an endophytic component to the growth, where it seems to be growing inwards, kind of intoing, as we like to say. So we have an exoendophytic growth with columns or tiers of parakeratosis overlying some of the hills in this papillomatosis. And then these really prominent foci of superficial blood vessels in the papillary layer. And as you can really appreciate, in some areas where the epidermis is quite thin, those blood vessels end up really high up and close to the surface. All right, so of course this is a wart, okay, Verruca vulgaris. One of the salient features that we appreciate on higher power is that once again, we have these coilocytes, these enlarged keratinocytes that have a clear or vacuolated cytoplasm and these small pycnotic nuclei, okay, and then we have increased keratohyalin granules and increase in this granular layer overall, okay, so those are the characteristic features. It is quite nice when we see those coilocytes so clearly. And then I was earlier alluding to an architectural finding where we have this thin epidermis and the blood vessels really close to the surface of the lesion. As you know, warts can bleed so easily, and this is a simple architectural reason. Those blood vessels are really quite highly exposed there. So in the two examples that we've seen so far of this category of viral infections, right? So we've seen Verruca plana, we've seen Verruca vulgaris. Of course, these are both caused by HPV, human papillomavirus subtypes. And we've appreciated that there's coilocytosis can be a feature. There's some architectural features as well. But what we noticed for both of these entities is that the part of the epidermis that's affected is really superficial. So we're sticking to the granular layer here. We're sticking to the upper portion of the stratum spinosum. And this is a simple part of the reason why these lesions can really persist and persist and persist. They're not exposed to the immune system, right? They're not exposed to immune mechanisms. And of course, we also know that they can be self-limiting. They can resolve eventually over time. But again, there's some immune protection by being so superficial in this way. And then we're going to take a look at some different entities that behave a little bit differently. Their cytopathic effect is not the same, and this partly explains why we have the kind of reactions that we see with those other entities. So keep that in mind. Let's reorient here as well. So this is marvelous to look at, right? So you have this really prominent orthokeratosis. You know, this is thick, and then you notice this pinkish, reddish blush between the stratum corneum and the epidermis. And that gives a clue that we may be looking at an acral area. We have a little bit of stratum lucidum here, right? And then what's most obvious, most striking is this exoendophytic growth with these almost like this anthill-like structure or pattern to the growth. As we zoom in here, we again appreciate that with this papillomatosis, you have some areas where there's this really thin epidermis, and the superficial blood vessels of the papillary dermis are really quite exposed. So you can imagine that this is something that can bleed fairly easily. And finally, we have our coilocytes. Again, we can see even at this power that you have these cells that are enlarged with clear looking cytoplasms, right? You can see that these are cellular, okay? So these are vacuolated as well. Going in a little closer, so some of these cells are really quite enlarged, but again, we see that these are discrete cells with a vacuolated cytoplasm. The cytoplasm is full in many areas of these inclusions. They are really solid, really dense, and they're multiple. Okay, so we have these conclusions. We also have our keratohyalin granules, right? So we have cytoplasmic inclusions as well as keratohyalin granules that are enlarged. And in some places, we even have some nuclear inclusions as well. What we also appreciate is that we have many of these cells, these keratinocytes, that are enlarged. They have eosinophilic inclusions. We also have many keratinocytes that have a more basophilic appearance to that intracytoplasmic component. So we have a bit of both. The keratinocytes, I would say, are a bit variable in size and shape here. And again, this is reflective of the variability of the inclusions in them. Some of them are really quite large and the inclusions are eosinophilic. Some of them are a little smaller. Maybe the inclusions are a little bit more basophilic. But one keratinocyte may not be the same size as another keratinocyte or the one next to it. And I believe you can see my my mouse here, my arrow. Okay, so just keep that in mind. You know, there's some variation in the size of these enlarged keratinocytes with their inclusions. Okay, so this is very characteristic of a myrmecial wart. All right, so still HPV, it just happens to be a wart pattern and appearance that is just very classic for these warts that occur on the feet. And they can be kind of interesting, you know, sometimes they can have melanin inside them, so they can be pigmented. But again, this is a characteristic appearance. Let's compare that now to the following entity. It's just taking a second to load here. There we go. Let's reorient again. Okay. All right, so at low power, we appreciate, this is a good example. So at low power, we appreciate that there is this lobulated epidermal proliferation, right? It's kind of pseudo-epitheliomatous is what I would say here. So there's certainly papillomatosis, but it's kind of pseudoepitheliomatous, okay? And there's quite some profound lymphocytic inflammation around it. But what's most striking to the eye is this densely eosinophilic area centrally. So let's go ahead and take a look at that. So we have these sheets of keratinocytes that have these intracytoplasmic inclusions that are just heavily, densely eosinophilic, right? So keratinocyte after keratinocyte after keratinocyte in this area has these eosinophilic inclusions in them, just sheets of them, and they're the same size. They're all around about the same size. As we go deeper into the granular layer, there is some basophilic breakdown around these inclusions. So that's something that we characteristically see in this particular diagnosis. You know, densely eosinophilic areas adjacent to strikingly basophilic ones. So this color pattern is very typical. This is molluscum. Okay, so molluscum, you know, so molluscum family that it belongs to. And again, what's kind of striking and different about this compared to the myrmecial wart is the amount of inflammation. This is not limited to the higher areas, to the upper areas of the epidermis, right? Certainly, some of our molluscum can get out beyond the epidermis and cause some inflammation. But we did point out with the myrmecial wart that, and again, this is the differential because it can look so similar. But we did point out how the keratinocytes varied quite a bit in size and shape. Whereas with the molluscum and the inclusions in the molluscum that is infecting these keratinocytes, these are all keratinocytes, right? Same kind of cell. But the keratinocytes here, they're huge because of the huge inclusions in them, but they're so similar to each other in a zone. Each one looks like the next one, looks like the next one, looks like the next one, all right, in each zone. And then let's just go back again to just get an eyeful of it. So for that myrmecial wart, you know, this, and I believe you can see my arrow here, but this keratinocyte compared to this keratinocyte compared to another keratinocyte, they're very variable in size and shape. So that is a bit of a help differentiating between these two entities that are on the differential diagnosis of each other. And then one other thing to add with the molluscum, well, two other things actually. So with the molluscum, it is not uncommon to see another diagnosis in a molluscum lesion. So just have an eye out for a twofer, right? Two diagnoses under the microscope. Not uncommon for them to be associated with a nevus or an epidermal cyst or even melanoma. So many entities have been associated along with molluscum histologically. Okay, so that's one. Okay, and then the second consideration for molluscum is that, as we know, these lesions can be self-limiting, right? They can regress. And it can be a little tricky diagnosing molluscum from a regressing lesion. You may not see those wonderful Henderson-Patterson bodies that we use, so we call them, right? These enlarged keratinocytes, we may not see them so clearly. We may have to kind of hunt for them, but hunt for them we should. When we start seeing this kind of pattern, this lobulation, there may be some inflammation, but the pseudoepitheliomatous pattern, which is something worth thinking about if you don't have a clear diagnosis. It could certainly be a regressing lesion of molluscum. Changing gears a bit. Let's go back to this case. Okay, so new case. All right, so we see a very well circumscribed, somewhat pedunculated lesion here. Okay, and what's striking is that we have quite some papillomatosis. The borders of this lesion, both at the epidermal surface and at the base, are very well demarcated, right? The basal layer margin is really quite clear, and that's quite characteristic of this diagnosis. Additionally, the acanthosis is really very dense and solid. It's strikingly different, I would say, from the other lesions that we've been looking at, even though this is also HPV, right? So this is going to be, this is condyloma. Now, a key finding is going to be the coilocytes. And you can appreciate, let me find a really good area for you, because the coilocytes can be very helpfully prominent in condyloma. Look at these coilocytes. We have our enlarged keratinocytes with this small, dark, dense basophilic nuclei, those pycnotic nuclei, and then the vacuolated cytoplasm around them, right? So there's a classic coilocytes. But look how far they go. You know, these are many, they are numerous, and they go deep into the stratum spinosum. Okay, they really are going quite dense in there. Okay, so this is a very prominent feature, quite a prominent feature of our condyloma, and they really help us make the diagnosis. All right, let's take a look at this entity. So at low power, when you look at this, the first thing you most likely think of is a wart. It has the architecture of it for sure, but look closer we must. And what we appreciate is that, yes, indeed, there is the warty architecture, but these cells are funny, right? So there are some cells that have a kind of blue nucleus, and they look like they have some clearing around them. So maybe we have a coilocyte or two. But when we look closer, some of these cells really look quite altered. First of all, we're seeing many more cells that, yes, they have some clearing around them. There's a bit of a halo, but they're actually more eosinophilic, right? There's a dark red purple quality to them. So there are lots more of those. So these are actually apoptotic cells, right? There's dyskeratosis going on here. And then we are seeing mitoses, mitosis after mitosis after mitosis. Okay, so there are lots of mitoses here. There's a lot of mitotic activity here. These cells are very pleomorphic. One does not look like the next, does not look like the next. You know, this is very atypical, right? A lot of atypia here. Okay, so we have a lesion with this kind of warty architecture. It happens to have in this case. But there is quite a bit of atypia here. So we're starting to think about, you know, could this be squamous cell carcinoma in situ, also known as Bowen's disease, right? But with the architecture, it just makes us think, and it's not really full thickness, it's Bowenoid. So what else could look like Bowen's disease, but not actually be Bowen's disease? So Bowenoid's papulosis, right? Now, to make that diagnosis, we do want to go back to the clinician and investigate. Is this a solitary lesion, or are there multiple of them? Because really, to make that diagnosis of Bowenoid papulosis, we want to hear that there are multiple. If it's solitary, we're going to be calling this Bowen's disease. But if they're multiple, then this is the appearance of Bowenoid papulosis. So just really, just remember that you need that clinical correlation, that there are multiple lesions in the area, in the perineal, or obviously this is going to be in the genital area that we're talking about this diagnosis, but you want to be clear that there are multiple lesions there to call this Bowenoid papulosis. Moving right along. So even at low power, we can see that, yes, there is some hyperkeratosis here. We can see our granular layer pretty well, but there is this basophilic blush to the epidermis that is just striking. You know, even when you can't see the details, you see that that blush, that basophilic blush to the epidermis, and you want to kind of focus in on that. Okay, and as we go into higher power, yes, we're seeing some colocytes, so we see some of those cells, but what's really striking to us is these large keratinocytes. Look how big they are. They are enormous. They are large, and they have this strikingly basophilic, kind of purplish cytoplasm. Okay. We have our nuclei, and we can see that the nuclei themselves seem to have a little bit of a halo directly around them. So that's interesting. And that is something that is seen in this diagnosis. So there is a bit of a halo, a perinuclear halo. And the nucleus itself may have some inclusions, fine, no problem. We can see that there are inclusions inside the cytoplasm too, where we have this basophilic coloring. But just the mere size and the color of these keratinocytes is really essentially quite diagnostic. So this is going to be EDV, epidermodysplasia verruciformis. Now, as you know, EDV and HPV are related infection. There's certain HPV subtypes that are associated with it, but it can, or rather squamous cell carcinoma can arise from these, right? Squamous cell can arise. So you want to look around and see if you have evidence of clear atypia. Just don't forget that, once you've made the diagnosis of EDV, great, yes. But at the same time, just be aware that they can be a malignancy, a frank SCC can arise from this. Okay. All right, so we're going to change gears a little. This looks like a good example. So at low power, we appreciate that this is a superficial and deep issue, right? We have some striking intraepidermal vesiculation that's fairly irregular. And then we have this lymphocytic, it appears, inflammation, but this dense inflammation that is certainly periappendigeal, as well as also looks like it's perivascular too, but it's really dense, really profound. Okay, and so initial thoughts at this point, you think immediately, perhaps this could be a bullous alley, a bullous lupus, perhaps this could be a bullous drug reaction, but we want to go in closer to investigate. And we want to start off always going top to bottom. So let's start with our epidermis. And look at that, you just have this profound acantholysis as the cause of this intraepidermal vesicle, right? So vesicle can have multiple different causes, and we can see that this is clearly acantholytic. We can see the separation of these keratinocytes, almost look like little buds at the edge, right? And so looking at the keratinocytes, looking a little bit more at their how they relate to each other. And we appreciate that some of these cells are huge. These are keratinocytes. Some of them are just big, and they have these multiple nuclei. They're multinucleated. And really the way that this is happening, this way that we're getting these multinucleated cells, is that the cellular membranes between them are breaking down. Essentially, the cells are swelling, and the membranes between them are breaking down, so you get this multinucleation. Okay, and then looking at the nuclei as well, taking a close-up, these nuclei are relating to each other. They're kind of conforming to each other. They're molding around each other. Okay, so this is what we call nuclear molding. And then finally, looking at the nuclei, there's a bit of a pattern that we tend to see. I'm going to try and find the best examples I can of this, where you have, this may be a good one. Okay, so you have the nuclei right there, dense and blue, but the chromatin, instead of being central, is kind of clumping at the edge of the nucleus. Okay, so it's something that we we just know happens with these this particular category of viral infection. But when you're looking at the nucleus, there is this clumping of the chromatin at the edge of the nucleus, and this is called margination. So when we see, excuse me, here we go. So when we see this pattern, where we have these giant cells with multinucleation, margination, and nuclear molding, we know that we're dealing with viral infection. That is a different kind of cytopathic effect, okay? And then there are just certain categories of viral infections that do this. It's mostly associated with the herpes viruses now, okay? So in terms of parsing between the various herpes viruses, so for example, HSV, herpes simplex virus versus Zoster, herpes zoster, there are different opinions about what they look like classically under the microscope. Some people characterize or say that HSV may have more of a folliculitis associated with it. Some people say that the VZV may have more hemorrhage associated with it, especially intra-epidermal. There may be some component of hemorrhage, which we have in this case. Certainly, you can have a bit of a neuritis or a localization of inflammation around nerves as well. And then there are various opinions about how inflammatory each of them are. Some people say that maybe the HSV is more inflammatory, but again, these are not hard and fast, and certainly they're always exceptions. So you want to get the PCR is the bottom line. So this happens to be a case of VZV, okay? So herpes zoster. So a couple of interesting comments and notes about herpes viruses in general, and then herpes zoster in particular. So first of all this inflammation we did not get this kind of inflammation with the papilloma viruses, right? We did not get this kind of inflammation with Verruca. And we talked about immune protection of a sort, so just being limited to the epidermal, higher epidermal areas, while with HSV, VZV, you're not getting that. The cells are bursting, right? They're filled with viral particles. The keratinocytes are filled with viral particles, and they burst. And all the cells of the epidermis, all the layers of the epidermis can be affected. So you can get breakdown and involvement with viral infection all the way to the basal layer. These cells burst, releasing the viral particles into the dermis, and you get this robust inflammatory reaction. You have polys, you have a full and profound inflammatory reaction possible, okay? So that's the first thing. We already talked about the different kind of cytopathic effect with the margination, multinucleation, and molding. And then with herpes zoster, some very interesting things can happen as the lesions are resolving or have a scar, essentially. Different reaction patterns have been seen in zoster scars. So you can certainly get a bit of a granulomatous reaction that's been identified. Granulomatous vasculitis has been characterized. Granuloma annulare, for example, a reactive perforating collagenosis is another possibility. So multiple different reaction patterns that you can see in more of a resolving zoster lesion. So that's quite interesting and worthy of thinking. Zoster can be tricky. You don't always have this wonderful vesiculation to help you along. There are scenarios where you really just have a vasculitis, a dermal vasculitis. So that can be very tricky. Even with and then you can also just get involvement of eccrine glands, and it's more of a nodular, clinically a nodular lesion that you see when you have zoster that's really kind of localized to the eccrine glands. So that's very tricky as well. Even when you have a vesicle, of course, you may not get such wonderful acantholysis and the 3 M's, you know, you may not have such a beautiful pattern immediately obvious. So you want to take a look at the edges of any vesicle that you have to really have your best opportunity to find this kind of cell. So, you know, always take a good look at the edges of the vesicle, and certainly that transition from involved epidermis to less or uninvolved. Okay. So that was a pretty nice case to look at. All right, so moving along to another diagnosis here. Okay, so at low power, we're so lucky to have a little help here because again, we see some pretty good compact orthokeratosis, but look, we have that kind of pink layer in between the stratum corneum and the epidermis. So we know that we are acral. We have a stratum lucidum here. And then we have this ulcer. And so we want to know what's going on, what's causing this ulceration. So we're going to take a good look there. But let's take a look at the edge of the lesion. Okay, let's see what help we can get from the edge. We have some papillomatosis. Okay, so that's worth noting. There's some spongiosis associated with that, so we want to pay attention to that because certainly that may be playing some sort of role in that ulcer that we are seeing. So let's keep that in mind. All right, and then let's dive into it. Let's dive into that ulcer. Let's see what we can see. And you know, as with ulcers, generally we want to look at the edges for the most useful information. And at the end of the day, an ulcer is an ulcer is an ulcer. All right, so let's take a look at the edges. And so what we're seeing is we have keratinocytes here, right? These are all our usual keratinocytes. There is essentially intraepidermal edema here. There's a clearness to them intracytoplasmically. So we have some intracellular edema, as well as what we had noticed before is that we have some pretty significant spacing between the keratinocytes, right? So we had some spongiosis out toward the edges, and now we just have frank kind of vesiculation where that interepidermal edema is expanding. Okay, so it's just essentially edema everywhere. Excuse me. Let's move this along. Okay, and then what we also appreciate when we take a closer look at these keratinocytes, yes, there's lots of edema, there's fluid in there, but we also have these inclusions inside. We can see that there are some intracytoplasmic inclusions. We're really seeing that in quite a few of these keratinocytes, right? So we want to keep that in mind. We have intracytoplasmic inclusions. So of course now we're thinking about cytopathic effect because that's a form of cytopathic effect. You can also have multinucleation. Okay, so you have some cells that we're seeing that have more than one nucleus. Okay, so multinucleation. So we're definitely thinking about cytopathic effect and that they could certainly be a virus at play here. And then as we're looking at the epidermis and how it's breaking down, you know, there is a bit of a pattern to it. Let's take a look at this area, for example. You have this kind of reticulation of the strands of epidermis that are left behind as the epidermal cells, kind of the keratinocytes, kind of get fill up with fluid and develop edema, and there's edema outside, and then they burst. You know, so that's how the epidermis is breaking down. But the ones that are remaining intact, they're remaining intact in this kind of stranding pattern that almost seems like it's creeping down. So this reticular degeneration. But you know, what's very striking in this particular diagnosis is how you have this epidermal stranding that seems to be, you know, is creeping down into the dermis. And of course, you know, that's very different from how we expect the epidermis. Obviously, this is also there's some acanthosis, but obviously we don't have that pattern typically. All right, so this is part of the diagnosis that is somewhat histologically diagnostic in the appropriate setting. Okay, so this is an example of ORF, right? Like thymocontagiosum. ORF being one of the orthopox viruses. So first of all, we appreciate how different a pattern of cytopathic effect we're seeing in this diagnosis compared to our HPV, for example, different even from our herpes, right? So papillomavirus pattern seems to be different from the herpes virus patterns, and the pox, the parapox versus orthopox. The different pox viruses also have their own somewhat characteristic presentations as well. Okay, so ORF, we get some help. ORF is typically going to be acral. It's usually through direct inoculation to people who have some contact with animals like sheep or the pastures that they live in. So it's a very kind of characteristic infection, and there has to be that opportunity for an animal contact. Okay, so that's also very helpful. Let's move on to the next diagnosis here. Well, actually, before we do that, one comment I want to make, and I just want you to keep in mind again this kind of stranding that we've looked at, as characteristic of the pox viruses. But I also want to make a side comment, and I don't have an example of monkeypox, but just talking about the pox viruses in general, vaccinia, smallpox, and monkeypox, you're going to get the very similar scenario where you have these areas of profound edema, intercellular and intracellular, resulting in this balloon degeneration and the reticular degeneration. So you can see all those things that something that is a little bit characteristic of smallpox and monkeypox is epidermal necrosis. Like you really see a necrosis as part of the histology. And then the intracytoplasmic inclusions in the keratinocytes, they're also somewhat characteristic. They tend to squash on the nucleus a little bit. They tend to push against the nucleus. That's where you find them, as somewhat perinuclear. They're very eosinophilic too. They have a name. They're called Guaraneri bodies, right? So the Guaraneri bodies are described in that group of pox viruses. So smallpox and monkeypox, and that's the name given to them. Okay, so now moving along. Okay, so this case is nice too, in that we have a little bit of help. We have all the keratosis here. We appreciate that there is a stratum lucidum here as well. Okay, so we know that we're acral, so that's really quite a big help. And then again, we do see that there is a focus of this edema, essentially. So this balloon degeneration where we have vesiculation that is just so scattered and irregular. It's really from edema. We know that this is kind of the pattern of vesiculation we see when it's derived from edema. And this is intercellular edema, and we can also see that inside the cells that there is edema as well. We're seeing these keratinocytes that are enlarged, and they have, okay, so these kind of enlarged keratinocytes, there's quite a bit of breakdown here. It's kind of hard to find a good keratinocyte, but here we go. We're seeing these keratinocytes that are enlarged. Yeah, and I think that's actually just a very good point. Again, we have less success finding more intact cells in the center of this kind of vesicular area. We're going to have more luck at the edges. Just remember that, keep that in mind. So at the peripheries of the intact epidermis. So taking a look at one of those epidermal edges, we appreciate that our keratinocytes are really enlarged. They have some clear areas, clear cytoplasmic areas. This is all intracellular edema, as well as intercellular edema that we're appreciating. Okay, so that balloon degeneration that's occurring. And you can see that there is a dense inflammation. We have polys just running in there and contributing to just kind of this mess that we're seeing. And at the edges, we have this kind of reticular degeneration where you have these strands of intact epidermis that are left behind. Okay, but looking around in this case, you know, you see your keratinocytes, you see all the changes that I mentioned, but there are a few things we're not seeing. We're really not seeing multinucleation. You know, we're not seeing that. You know, you have the big keratinocytes because of all the fluid, but they're not forming these syncytia. You're not getting multiple cells kind of fusing together, right? So that's something to take note of. Okay, and then we don't really appreciate inclusions per se. Again, it's fluid. It's a lot of fluid that is inside the cytoplasm. Okay. Okay, so again, this was acral. We have that pattern of reticular degeneration without any multinucleation or the development of intracytoplasmic inclusions. So this happens to be hand, foot, and mouth syndrome, which is typically caused by Coxsackie 16 and enterovirus 71 is less common, but can be associated, of course, more in kids. You know, so kind of the right clinical picture too. But this is an example of hand, foot, and mouth syndrome. So just again, keep in mind that we have a reticular degeneration balloon degeneration without the specific viral cytopathic effects, so to speak. Okay. And then this case, you know, just to make the point, including it, this is so non-specific, and that's really kind of the point. You know, you have this papule, you have some somewhat compact hyperkeratosis, and then obviously you have vesiculation, right? So you have spongiosis, background spongiosis, and you have this vesiculation with some polys running in there and a bit of a superficial perivascular and interstitial inflammation, right? It's a bit of a mixed pattern there. And there's really not a whole lot to say about the vesiculation. Certainly, first of all, we don't see that epidermal strand. And so, you know, this is a scenario where we can do some, we can compare it to our previous case and really appreciate what's not there. So we have vesiculation, but it's quite irregular. This is kind of nice, round, well-behaved vesicle. You don't have that ballooning degeneration. You don't have that reticular stranding, reticular degeneration, and epidermal stranding that we were seeing as so characteristic of both the ORF and the hand, foot, and mouth. Okay, and then we certainly don't have any viral cytopathic effect here of any kind. We don't see the multinucleation. We don't see margination or molding. You know, these keratinocytes, there's edema, there's inflammation. You know, we got the spongiosis and the inflammation, but not a whole lot more. Okay. Well, so this is quite non-specific. We can imagine that this may be a diagnosis where the point is not so much that the virus is in the lesion, but this is an immune reaction or immune response to there being virus present somewhere. And this is the one, you know, this is one I'm including this, that is interesting in that regard, but this is Gianotti-Crosti syndrome, which certainly is considered more of a childhood syndrome, secondary to a viral infection. And HBV was really the first that was described in the primary one it's being described in, but it's been described in many since then, including COVID, right? And so again, it's just a really kind of non-specific spongiotic pattern with intraepidermal vesicles in the setting of a systemic viral infection. Okay, but again, the point is you're not seeing viral cytopathic effect per se. You don't see the changes of the various kinds of viral cytopathic effect that we've discussed today. So it is a different kind of entity in that regard. Okay, so I think we've had an opportunity to really summarize quite well the various presentations of viral infections in the skin. You know, just for fun, I'm going to include very quickly one last one because it's just so unique, but also so diagnostic when you see it. Okay. All right. So, you know, shooting right into the diagnosis, running straight into it, you just see this expansion of the hair. And look at those granules, those trichohyalin granules. They are just so many. This is not normal. This is atypical. This is something that you just do not see in a normal hair follicle. Look at those trichohyalin granules. It is chock-a-block full of them. And then you also tend to get this persistence of the outer root sheet all the way up to the isthmus. So kind of the opposite of what we see with CCCA, right? Centrifugal cicatricial alopecia, so quite the opposite. You get this persistence of the outer root sheath and expansion of the inner root sheath. But most importantly, this is a diagnostic piece, the trichohyalin granules. Okay, so see that this is an example of Trichodysplasia spinulosa, which is a typically viral associated. And the particular virus is thought to be polyoma virus. The person that you're going to see this in is typically an individual who's had a renal transplant, or he's had a transplant of some kind, but more often renal, or they may be on cyclosporin. You know, it's also being described in the setting of cyclosporin use, or even just some other chemotherapy. So that's the kind of host or individual that you're going to see this pretty neat, unique diagnosis in. So that's it for today. We've had a good opportunity to review viral infections, to talk about the various different types of viral cytopathic effect in a way that is diagnostically useful. And again, that's most of the point, that we can really use this information, these histologic findings that we are learning and seeing to differentiate between sometimes very similar diagnoses.
Well, thank you very much, Dr. Maloney. Excellent presentation. Again, if anybody has any questions, please feel free to forward them to education@sagisdx.com. We will be happy to answer them. Hope everybody has a good evening. Thank you.